Hello friends, greeting from RFATUTORS, your mentor this side with the Green Top Guideline of the day. Today we are here to discuss about the management of bladder pain syndrome, the Green Top Guideline number 70, published in December year 2016. The widespread definition for BPS is that proposed by the European Society for the Study of BPS in 2008 as pelvic pain, pressure, or discomfort perceived to be related to the bladder, lasting at least 6 months and accompanied by at least one other urinary symptom. For example, persistent urge to void a frequency in the absence of other identifiable causes. American Urological Association has described BPS as an unpleasant sensation, the pain, the pressure, the discomfort perceived to related urinary bladder associated with lower urinary tract symptoms of more than 6 weeks duration in the absence of infection or other identifiable causes. An important single best answer to pick up in the extended match question. This scenario is very important. The BPS may be associated with negative cognitive, behavioral, sexual, or emotional consequences, as well as symptoms suggestive of sexual dysfunction, according to the European Association of Urology. A large American study found prevalence rates of 2.3 to 6.5%. BPS is between 2 and 5 times more common in women than men. This guideline aims to provide evidence-based information for primary and secondary care clinicians on the symptoms and treatment options for bladder pain syndrome in women, together with an appreciation of the current uncertainties surrounding this condition. A very important single best answer. Bladder pain syndrome is a chronic pain syndrome, and the principles of management of chronic pain should be used for the initial assessment of this condition. A thorough medical history should be taken and physical examination to be performed. A bladder diary, frequency volume chart should be completed. A food diary may be used to identify if specific foods cause a flare-up of symptoms. Urine should be tested to rule out a urinary tract infection, as this is a prerequisite for diagnosis of BPS. Investigations for urinary urea plasma and chlamydia can be considered in symptomatic patients with negative urine cultures and pyuria. In those with a suspicion of urological malignancy, urine cytology should be tested. Cystoscopy and referral to urology should be initiated in accordance with the local protocols. BPS is a diagnosis of exclusion, and other conditions should be excluded. The bladder biopsies and hydrodistension are not recommended for the diagnosis of BPS. Cystoscopy does not confirm or exclude the diagnosis of BPS, but is required to exclude other conditions that mimic bladder pain syndrome. The potassium sensitivity test, urodynamic assessment, and urinary biomarkers should not be used in the diagnosis of BPS. Urodynamic test may be considered if there is coexisting bladder pain syndrome and overactive bladder that are not responsive to the treatments. Very important exam question. The clinicians should use a validated symptom score to assess the baseline severity of bladder pain syndrome and assess response to the treatment. The use of visual analog scales for pain should be considered to assess severity of the pain in bladder pain syndrome. The patients with bladder pain syndrome can have a low self-esteem, sexual dysfunction, and reduced quality of life. The patients with bladder pain syndrome may have other coexistent conditions impacting on their quality of life. The classification of bladder pain syndrome according to the cystoscopy and biopsy findings. The most important part of this Green Top guideline is the treatment algorithm, starting from the initial assessment, first-line treatments, second-line treatments, the third-line treatments, the fourth-line treatments, and the fifth-line treatments as well. A very important exam question tends to come from Appendix 4. Dietary modification can be beneficial, and avoidance of caffeine, alcohol, and acidic foods and drinks should be considered. The stress management may be recommended, and regular exercise can be beneficial. Analgesia is recommended for the symptom of pelvic or bladder pain. However, we have limited data on the benefits of acupuncture. Oral amitriptyline or samaritin may be considered when first-line conservative treatments they have failed, a very important single best answer. The cimetidine is not licensed to treat BPS and should only be commenced by a clinician specialized to treat this condition. If conservative and oral treatments have been unsuccessful, other therapies may be added or substituted using an individualized approach. And this will depend on the experience and expertise of the clinical team involved, and onward referral to a specialist center with expertise in chronic pain management and access to the professional forum, other specialties to provide a multidisciplinary approach care, it may be appropriate. The options of the intravesical treatment are lidocaine, hyaluronic acid, botulinum toxin A, dimethyl sulfoxide, heparin, chondroitin sulfate. The further options should only be considered after referral to a pain clinic and discussion at a multidisciplinary team meeting. Cystoscopic fulguration and laser treatment and transurethral resection of lesion can be considered if Hunner lesions are identified at cystoscopy. The neuromodulation and oral cyclosporin, it may be considered after conservative management. Cystoscopy with or without hydrodistension may be considered if conservative and oral treatments they have failed. Oral hydroxyzine does not appear to be effective treatment for bladder pain syndrome. Oral pentosan polysulfate does not appear to be an effective treatment for bladder pain syndrome. Long-term antibiotics, intravesical resin ferritoxin, intravesical bacillus calmette guarin, high pressure, long duration, hydrodistension, and long-term oral glucocorticoids are therapies that are not recommended, I repeat, not recommended for bladder pain syndrome. The further management, history, urine analysis, physical examination, they should be in the primary care, and the ones who fail to respond to the conservative treatment should be referred to the secondary care. Referral to the physiotherapist should be considered as bladder pain syndrome symptoms may be improved with physical therapy. The patients with refractory bladder pain syndrome should be referred to the MDT in order to explore alternative treatment options, an important single best answer. The patients should be given written information about patient's organization and evidence-based information. The patients should be followed up periodically in secondary care with consideration for shared care between the pain team and urogynecology until symptoms become controlled, and then they can be followed in primary care if required. The bladder pain syndrome treatment options considered safe in pregnancy include oral amitriptyline and intravesical heparin, although one course of DMSO may be used prior to pregnancy for symptom remission with good pregnancy outcomes. Important single best answer. Friends, few important exam points for bladder pain syndrome are the bladder pain syndrome definition for the extended match question. The most important part which comes in exam is the management algorithm in a sequential manner. Good luck from the entire team of RFA Tutors. I thank you for joining us today. See you next time, and until we meet again, take very good care of yourself. Bye-bye.